And today I would like to talk about the safety of NOACs for thromboembolic prevention in patients with Fontan circulation. These are my disclosures. So thromboembolism in Fontan patients, as we all know, is a serious issue. The incidence of thromboembolism ranges from 4 to 20%, and on the left picture in the Kaplan-Meier graph, you can see the increasing risk of thromboembolism right after the Fontan operation under different antiplatelet therapies. But not only is the symptomatic or clinically prevalent thromboembolism is important, but also the prevalence of silent pulmonary embolism is high, up to 17% in these patients. And such chronic microemboli in pulmonary vascular could also raise the pulmonary vascular resistance. And you can see that, for example, in Fontan patients on the right graph, where you can see that while the PVR increases, the circulatory output also decreases, which means that it adds to the more reason why this should be prevented. So in order to prevent the devastating consequences of thromboembolism, the American guidelines have said that, Fontan patients with documented atrial shunt, atrial thrombus, atrial arrhythmias, or a prior thromboembolic events should all receive oral anticoagulants. And 2010 European guidelines of Gooch has recommended the similar indications, except for the exclusion of documented atrial shunt. And of course, in clinical practice, we also wonder whether all patients with Fontan circulation should go on anticoagulation or not. There are still ongoing discussions on this indication. So as anticoagulation is important, which is specified by the guidelines too for atrial arrhythmias, the 2014 guidelines from PACES and HRS on arrhythmias in adult congenital heart disease have actually given a recommendation level of 3, which means that they discourage to use NOACs, which is non-vitamin K oral K antagonist oral anticoagulants in patients with Fontan circulation in atrial arrhythmias, with a reason that there is no evidence. But of course, this advice is also based on no evidence. Just as an introduction to show about NOACs, NOACs differ a lot from vitamin K antagonists in terms of their targeting points in the coagulation cascade, but also in their pharmacokinetic properties. So in general population with atrial fibrillation, the NOACs have shown a lot of beneficial effect compared with vitamin K antagonists. Here you see the pooled results from meta-analysis by Ruff et al. In Lancet in 2014. And you see that the combined effect on systematic embolism or stroke was beneficial for NOACs compared with vitamin K antagonists, and also the intracranial hemorrhage. So the guidelines currently discourage the use of NOACs in Fontan patients without any evidence, and at the same time, NOACs are increasingly still used in Fontan patients without any evidence. Furthermore, these young Fontan patients would like to maximize their active lifestyle and at the same time also minimize the medical interventions they could have. So we wonder if NOACs could not be a good alternative than vitamin K antagonists. So to answer this question, we have used the data from the NOTE registry, which is a prospective registry of all ACHD patients using NOACs for thromboembolic prevention. So our question is, are NOACs safe and effective in preventing thromboembolism in adults with Fontan circulation? Well, the design I've just said before, from all the ACHD patients using NOACs, we've included only patients with Fontan circulation. It is an international multi-center open prospective cohort study, and we do a follow-up at 6 months and yearly thereafter. And as primary endpoint, we've chosen thromboembolism and major bleeding, and as secondary endpoints, we've chosen minor bleeding, side effects of NOACs, death, and myocardial infarction. So through the international collaborations with 32 centers currently actively recruiting patients on NOACs, out of total of 346 ACHD patients with NOACs, we've included 57 patients with Fontan. These are the baseline characteristics of the 57 Fontan patients as they are. You can see as they're young, and most of the indication for the NOACs was non-valvular atrial arrhythmia, and a smaller proportion has used it for the prevention of thromboembolism in Fontan circulation, and one for the management of intracardiac thrombus. And if you look at the risk stratification with CHA2DS2-VASc and HAS-BLED, they are low as to be expected in these young patients without typical vascular risk factors. And half of these patients have used vitamin K antagonist in the past, and the quarter of them use antiplatelet therapy or no previous antithrombotic therapies in the past. And majority of these patients has a TCPC kind Fontan, and a smaller proportion has an atrial-pulmonary connection. So this is the Kaplan-Meier of freedom from the first thromboembolic events with the the time from years since the start of the follow-up. And what you see is that in green line, this is the line for the NOACs with 0 thromboembolic events so far. And this is not totally correct, but we used it just to illustrate and give a sense of reference. We used the historical data of the vitamin K antagonist users among these NOAC patients, which were 25 patients we could find, and we've put it in their historical data next to our data. And you see that in a long-term follow-up, these vitamin K antagonist patients had 2 thromboembolic events. And now it's the same Kaplan-Meier, but for the freedom from the first major bleeding. And you see that so far there has been 2 major bleeding events in the group of NOAC with a green line, and in the vitamin K antagonist in the long term, there were only 1 major event. So in conclusion, total follow-up of 57 Fontan patients were followed up with a median follow-up period of 1.2 years, and there was no thromboembolism occurred, and also there were 2 major bleeding, one that was gastrointestinal and the other was menorrhagia. And in total, there were 3 clinically relevant bleedings and 7 minor bleedings. As side effects, vasculitis and taste disorder have been reported, and there were in total so far 11 dropouts, mostly due to the bleeding that I've just mentioned before and the side effects. And other than that, there were also issues of pregnancy or no reimbursement for the costs, or Fontan conversions and deaths due to end-stage heart failure and cancer. So based on this preliminary results, we think that NOACs in Fontan patients are safe and effective during over 1.2 years of follow-up, and we feel that the future guidelines should not exclude NOACs as a treatment option for thromboembolic prevention in Fontan patients. Of course, this study has a selection bias. Some of the patients were switched from vitamin K antagonists to NOACs because of the label INR or because they had a bleeding event before. And some have been put on NOACs because they are young patients with relatively less risk. So there's a bit of a mix of selection bias in this group. And further, we also need a larger inclusion number and longer follow-up to really establish the safety and efficacy of NOACs. So this registry node will continue to provide data in all ACHD patients using NOACs for the coming 3 years. So if there are any new centers who would like to collaborate with us, they are welcome. So as last, I really want to thank all the contributing participants worldwide. These are all the people that are involved in our registry, and without them, we would have never gained such data. So thank you.
Very impressive to pull multinational data together like this. So, Questions from the floor, Rafa.
Congratulations for the presentation and for the work. Just one question. So, have you noticed whether, or you have the data, whether the patients that have more bleeding events relates to a particular NOAC, so to a particular type of drug? So, in our experience, Fontan patients tolerate very well apixaban, but don't tolerate others. So the liver gets significantly impaired, and the PTT increase significantly with rivaroxaban and with dabigatran. I wonder whether that's the reason that they have more bleeding events.
Well, thank you. Well, in general population, I do know, for example, apixaban has the best benefits in terms of major bleeding and gastrointestinal bleeding. But in our patient group, I think it's hard to say whether those two major bleeding was because of the type of the NOAC they have used. I think we need to have more events to really verify that. But I cannot really find that kind of structure right now. According to the current
Just
data.
is a comment. So we start NOACs always as an inpatient, and when you monitor the liver, the APTT of the Fontan patients with any kind of NOAC, that's not apixaban, you have, in 72 hours, you have the patient with a significant raised APTT with an INR of 1.8 or 1.9 with no warfarin. You change that, you stop the NOAC, you start apixaban, and normally majority of them don't have any change in the liver. So I wonder whether that is one of risk factors to have more bleeding events. I don't know, just that is a personal appreciation. We have several patients on NOACs, and that was a personal observation.
Okay, thank you.
Next question.
Well, thank you very much on a very excellent presentation, actually, and very nice data. I definitely want to comment on one important thing, which is the request to try to scrap and scratch that level 3 indication or the class 3 indication for NOACs and Fontan patients, because I think it's discussing putting those patients on NOACs fairly difficult. It's more than one time you get into an episode where like, oh yeah, maybe because there's a passive flow component that mimics the valvular AFib kind of problem, that's why we can't use them, but in this patient it might work. And after like a nice 5-10 minutes of academic discussion, it's like, you know what, it's class 3 indication, let's move on. And I think it's unfortunate because we're missing out on a possible therapy that can be really helpful, and in the general population is causing less bleeding in patients that already have a disease burden that's making it already impossible to manage with the regular disease problem.
Yeah.
So thank you very much for asking that the class 3 indication be removed on those medications.
Yes, I guess it also depends on the country, but in US I've heard that reimbursement for NOACs become extremely difficult if such a guideline indication is set to 3. It's almost not impossible to get them reimbursement for this indication. So yeah, that is unfortunate.
Okay, I have another question. So, of course, one of the big advantages of NOACs is that you don't need to control the INR, but there's also the risk that patients are not taking their medication you don't know. So do you have any data on medication adherence for NOACs in your population, and do you have any ideas on how to make sure patients are taking their medications?
Well, I don't have the data yet, but we are collecting the data on the adherence, one by doing a questionnaire called Morisky 8 questionnaire we take to ask the patient themselves whether they're taking the medications every day. And secondly, we, in countries that it is possible, in participant countries, we try to look at also the pharmacy data to see whether the pills that patients has collected over the period they've done, so that is correlated to the medication they should have actually taken during those days they visited the pharmacy. So those data we will be collecting, it's just I can't say for now what the data results are. And the ways to improve the adherence and to check, I guess the best way is to honestly talk to the patient, because I sometimes have the feeling that the doctors just assume that patients all take anticoagulants on a daily basis. But sometimes when I talk to these patients, they actually don't even really understand why they have to take the anticoagulation and how serious it is that they don't. So I think even though we all have short time and we're all busy, as cardiologists, for someone who's using NOACs, you have to ask every time you see them whether that's going well or not, and honestly talk to the patient about that. It could be difficult and that we could help them because patients tend to also lie, of course, if you ask them straight to their face.
Last question.
Thank you. I just want to commend you on the research that you're doing. It's a very important topic. I would suggest as you move forward in collecting this data that it might be worthwhile speaking with both the sponsors and the FDA for developing systems by which to collect appropriate data to influence PK and PD, the pharmacokinetic data, to actually get labels changed for these drugs. It might be something to consider as you move forward with your research collection.
Okay, thank you.
Okay, thank you everybody for this excellent session.